Hey, everybody. My name is Ryan Feldman. I'm an emergency medicine pharmacist and clinical toxicologist. And if you're here, it's because you're going to learn about my favorite pharmacology hack, the Benadryl block, or how we can harness diphenhydramine sodium channel blocking properties for good. So, if you ever run into a case where you have a patient with both an ester and an amide allergy, this is a great pharmacologic hack to keep in your back pocket so you can still take care of that patient.
We'll start with a case. Laura is a 39-year-old female presenting to the ED after a traumatic roller skating accident. She has a deep forearm laceration that needs repair, but on interview, she states, "I was hospitalized for a day after receiving Procaine, and I also get hives and shortness of breath from bupivacaine." You can't find any history of her receiving local anesthetics in your EMR. You are consulted to find an agent to anesthetize Laura. So, managing local anesthetic allergies. I'd love to dive more into this, but we only have 5 minutes, so I'm going to focus on the strategy of choosing a structural alternative to whatever they're allergic to. Meaning, if they have an amide allergy, you choose an ester. And if they have an ester allergy, you choose an amide. Most of us remember that if you have two I's, it's an amide, and everything else is an ester. Here's a non-exhaustive list of some common ester and amide local anesthetics. But if we go back to Laura's history, we note she's allergic to both esters and amides. So what do we do? Maybe we need to go a little deeper into what it means to be an ester or amide anesthetic. It's actually referring to a bond that connects a hydrophobic aromatic ring to a hydrophilic tertiary amine group. The hydrophobic aromatic ring is very important for cell entry and positioning the drug within the sodium channel. And the hydrophilic tertiary amine group will get protonated when it's in the sodium channel and actually repel incoming positive sodium charges. So, are there any other drugs with hydrophobic aromatic rings connected to tertiary amines that can block sodium channels? Yes. Introducing an ether, diphenhydramine, two aromatic rings connected to a tertiary amine group by an ether. There's a lot of drugs that have sodium channel blockade properties. But we've been studying diphenhydramine and its effect as a local anesthetic from its sodium channel blockade since the 1930s. Here are 5 randomized controlled trials. We only have 5 minutes, so I'm going to summarize the data for you, but you can read this on your own. Diphenhydramine has been shown to be equal in analgesia to 1% lidocaine. Primarily, the 1% diphenhydramine has been studied. One notable exception is injection site pain is worse with diphenhydramine, but overall analgesia is the same. It has an onset of about 5 minutes and a duration of 45 minutes, which is shorter than lidocaine. So we have bountiful efficacy data. You could say we have more randomized control trials than certain anti-10A reversal agents. But do we have the safety data? Well, you are injecting a sedative into patients, so drowsiness can occur, although it's not commonly reported in the trials. But you need to monitor for it and potentially institute driving precautions after use. Then there's this little hiccup of the package insert saying you should avoid its use as a local anesthetic due to the potential for skin necrosis. This is from 2 case reports in the 1980s, where 5% diphenhydramine was injected into ischemic-prone areas, like the digits, and one of those cases needed a fingertip amputation. Since then, we've had a ton of data with lower percentage of diphenhydramine, and out of nearly 900 injections, only 1 case of necrosis was reported. It was an intradermal injection to the forearm, and it was self-limiting, with no long-term effects. So, safety, yes, skin necrosis can happen, way less likely with the 1%, but don't inject high concentrations into areas of low perfusion, and watch out for drowsiness. To actually make this, you're going to take the 1 milliliter of 5% diphenhydramine and mix it with 4 milliliters of normal saline to get 5 milliliters of 1% diphenhydramine. Back to Laura. We were unable to rule out a true allergy to her local anesthetics or do skin testing, so she received 2.5 milliliters of intradermal 1% diphenhydramine and had her laceration repaired. A happy ending. Our takeaways from today. Diphenhydramine is a sodium channel blocker readily available in most emergency departments or clinics. It is a convenient alternative local anesthetic when other options are not reasonable. It's not ideal, as it has more injection pain and a shorter duration, as well as risks of necrosis and sedation. But this isn't an ideal situation when a patient cannot tolerate amide or ester anesthetics. The risks of necrosis should be weighed against the alternative agents. Consider shared decision-making with the patient. Is this procedure needed? And if so, is the risk of necrosis greater than the risks of general anesthesia or the need for skin testing, which has risk for anaphylaxis? You should always avoid injecting high concentrations into ischemic-prone areas to ameliorate the risk of necrosis.
All right, that'll wrap it up. I hope you can drop this pharmacology pearl on your colleagues the next time you're in the emergency department and blow a couple of minds. If you have any questions for me, reach out on Twitter at empoisonpharmd, and thanks for listening.